Okay, hello everybody. Thank you for joining us for another webinar, online webinar with in our platform, Virtual Global Spine. I'll be speaking tonight. Go over some cases. We have the neurosurgical upcoming oral boards, and I found that it's a good opportunity for me to give some tips how to handle the oral boards and how to go through cases. So, first and foremost, talking to residents and junior faculty, be serious, be prepared. Leading to it, you got to read maybe 30 to 60 minutes a day, and then maybe dedicate 2 or 3 weeks of dedicated time free from clinical obligations to really study for it and be in the zone. The exam is really about knowledge and strategy, and if I want to pick, I'll pick strategy over knowledge, going through cases. There are no tricks. It's a pretty fair exam. Actually, the examiner wants the applicant to pass, and they want to go through 5 cases over 45 or 50 minutes. So they'll pace you, and they'll ensure that you're progressing well with the case. They don't want to stall. They don't want to give you any tricks. It's just a fair exam, and it's mainly about safety. And about, they want to ensure that you're a safe surgeon and you know how to address and handle common pathologies. No zebras, no rare pathologies. It's pretty standardized in neurosurgery over the past few years. Those cases are pretty standardized, so everybody gets to be examined on the same cases. So it's a surgical exam. On average, you'll go over 15 cases in 3 sessions. However, there will be one non-surgical case, either related to inflammation, multiple sclerosis, ALS, vitamin B12 deficiency, and so forth. And the most important thing leading into the oral boards is just really practice with colleagues and mentors who've gone through the oral boards, and that's extremely valuable. It's as valuable as preparing for it. So a little bit of, I'll go over some tips. Anytime you see a trauma, either a traumatic brain injury or traumatic fracture, think of ABCs. So you see the trauma, you don't want to take the patient to surgery right away. You want to check the ABCs, make sure that the patient's hemodynamically stable. And just mentioning this is sufficient, that you thought of it and, cleared, you get to D, the disability, which is a neurological exam. You do that, and then you can proceed with managing the patient appropriately. And always keep a wide differential diagnosis. I know this is a virtual global spine platform, but this is an example how to keep a wide differential diagnosis. When you look at these 3 MRIs, you would notice that you have a ring-enhancing lesion. You don't want to jump and say this is like a metastasis or a GBM. You always want to keep the differential diagnosis broad. You can say, okay, ring-enhancing lesion can represent a tumor, infection, or inflammation. And they look at other sequences to narrow down the differential diagnosis, leading into a diagnosis and then the appropriate treatment. So far on the left side, that's a GBM. This is, you look at the middle image, it's actually an abscess because it restricts to diffusion. So you need to ask about the DWI sequence. And far to the right is an incomplete ring-enhancing lesion, which is pathognomonic of tumefactive MS. So you don't want to biopsy this far right lesion or resect it, because you can diagnose it with just CSF sampling, looking for oligoclonal bands. And the treatment of this is non-surgical. Actually, if you biopsy it, it will bleed potentially heavily. So you don't want to biopsy it, otherwise you'll fail that specific case. Again, more of the same. You don't want to biopsy inflammation. This is an MR that shows ill-defined enhancing lesion in the spinal cord, intramedullary lesion. The examiner would ask you to biopsy it, and you would say no, and you would start with a sampling CSF, and you can diagnose it if it's a transverse myelitis versus neurosarcoidosis, get an ACE level, and so forth. So see, this lesion has been treated with methotrexate and steroids and with near resolution of the lesion. Also, be critical of assessing a radiograph. This is a patient who presents with lower extremity weakness. You don't want to jump at and saying the patient has spinal stenosis and you're missing on signal cord change in the conus and the spinal cord that is secondary to dural AV fistula. And when you after each, like every case would be will be ending with a complication. So be prepared to manage these complications. They are not infinite. There are certain complications that you should be prepared to answer. And always think, when you think of a complication, think of an algorithm. You got to go through the algorithm. It will be second nature to you when you handle these complications. Don't want to think about it because. And I want to focus here on CSF leaks and changes in neural monitoring signals. You need to have a CSF leak, you bring the patient back, open it up, get the scope in, find the dural edges, tuck the nerves in. If you can primarily repair it, you can do so. Otherwise, you put a patch, then CSF tight closure, and you put a lumbar drain for 7 days. So you want to go through the algorithm fast because you don't want to lose time, and you want to show the examiner that you're prepared, like you're prepared for this exam. You don't want to think about it. Should be second nature to manage status epilepticus, dural sinus injury, air embolism, ICP management, and certainly if you're choosing to take a subspecialized session, CSF leaks, and changes in neural monitoring signals. Actually, I got like maybe 5 CSF leaks in my exam that I managed the same. So here I put together a small primer that was published a couple of, I think last year or the year before, in the AANS journal, AANS spine journal. So this can be handy how to address cases and how to strategically go through cases, interpreting radiographs, making a diagnosis, surgically managing them, and managing complication. So we'll start with this first case. And I tried to put some high yield cases that kind of you may encounter in the oral boards. So this is a 72-year-old man who started complaining of progressive weakness and numbness affecting his lower extremities over the course of a month. He complained of gait imbalance, suffered 3 falls. He reported urinary frequency. And then that's his past medical history: concomitant for atrial fibrillation, and then appendectomy, drinks a glass of wine a day, retired banker. And then moving to the neurological exam, his motor strength in the upper extremities were 5 out of 5, and the lowers 4 out of 5. And he had a sensory level at T8, brisk reflexes in the lower extremities, normal in the uppers, and had a positive Romberg sign. So the first big question that examiner may ask is, where is the lesion? Where you would expect the lesion is, localizing the lesion is really important in spine surgery, neurosurgery, and neurosciences. So we have our chat box, so please feel free to, this gives it away. So it's going to be the thoracic spine.
I'm trying to see if we can get any brave souls to jump on. I don't want to put anybody on the spot, but I notice a few names here of colleagues who probably are getting ready to take the actual exam. So we'll see if anybody wants to step up.
Remember, it'll be recorded forever on YouTube.
I was hoping not to highlight that part.
Oh, sorry. I'm sorry. I should have said anything. Okay.
Nader, I'm an orthopedic surgeon, so if I manage to take the first case, maybe I can break some eyes.
Okay, great, excellent, Alex. You're always there for the rescue. Okay.
Yeah.
So where do you think the lesion is?
Yeah. So when I see a sensory level of T8 and I see a motor weakness in the lower extremities, I would say it could be anywhere. But not in the lumbar spine. It must be cervical or thoracic or even the brain. But I say I will have to look for thoracic spine and cervical spine as well. You didn't mention any pain. Was this a painful lesion or
No,
pain-free?
painless weakness, and as brisk reflex in lower extremities, has a sensory level at about T8, and then brisk reflexes in the lower extremities. And so the uppers are intact in terms of neurological exam.
Check the whole spine, C-spine and T-spine, please.
Sounds good. So this is the thoracic spine MR. What do you see?
I can see this is level T7, T8. I can see a herniated disc is compressing the spinal cord, mainly from anterior. I can see a signal change intramedullary, signs of myelopathy, and I can see the lesion is pretty straight in the medial median part, and it's an anterior compression. Yes.
Yeah, I mean the radiologist agrees with you. He thinks it's a bit off to the left side. Let's say that's kind of an obscure image, not necessarily in the center. So this is a little bit off to the left side, but kind of certainly displaces the cord posteriorly. So what would you want to do about this? So do you think this explains the patient's symptoms?
Yeah, pretty well. Yeah, I think that can explain the symptoms pretty well. Yes.
So, Alex, what do you want to do? How do you want to approach this? How do you want to manage this? Do you want to send the patient to physical therapy and then have it come back in 3 months, or give them some gabapentin? Or
I think this is a significant functional problem, and I would need some further investigations in the radiology department, like a CAT scan and a T-spine. Have a look whether the thoracic disc is calcified or whether it's a soft hernia. These are my main concerns. And then I think it is better to go straight to the surgical treatment and not wasting time with physiotherapy. It's a risk of progressive weakness. You can always observe and have a look whether the symptoms are getting better, but I would choose surgery.
Good. So as you mentioned, you asked for the thoracic CT to rule out a calcified disc. Do you think this is T7, that's T8? Do you think this is a calcified disc or it's a soft disc?
Yeah, I think the disc itself, it's soft, but there are some retrospondylophytes, osteophytes, showing that is the changes is chronic. It's maybe narrow for a longer time, but now the soft hernia is causing the worsening, and I see some air trapped in the disc, signs of a DDD. So I think it's a soft disc.
Good. Okay, Alex. So how do you want to manage it? This is a soft disc and off to the left side, not necessarily central. How do you want to approach this, and how can you localize the lesion intraoperatively?
Yeah, so the level should be found easily in the fluoroscopy. I think we can do it classic with a wide approach, a big surgery, costotransversectomy, trying to get this out in a microsurgical manner. We can try to minimize the approach by going retropleural from a more lateral access. We can find a surgeon who does it endoscopically, everything from the left side. And you know, the smaller you go, the less you're able to use ultrasound. If you do it with an open access, you can always monitor and examine everything with the intra-op ultrasound. Otherwise, it's hard to make an imaging intra-op.
Okay, sounds good. So you want to take this patient and do a dorsal approach, like a transpedicular decompression posteriorly with a transpedicular approach to the disc. All right, so so you're positioning the patient. Obviously, you're going to use neural monitoring, correct?
Yes, I would always use monitoring for these. Yeah.
Okay, so one way to localize the lesion is to place a fiducial. This is something that we usually do, so preoperatively, and then you can do a post-op CT scan to confirm that that's the right level. This would help you with localizing the level appropriately, so and easily instead of counting ribs. And so that's one way to improve localization with fidelity. Okay, so this is the interruptive picture. That's cranial, that's caudal. Okay, this is the left side. What do you see here? So there's a decompression here, laminectomy, facetectomy, and then we remove the pedicle here. Sorry, we remove the pedicle here. So what do you see?
Yeah, I see nicely.
What is this?
This is a dura. We see vessels on the dura, and it seems to be intact. I can't see any leak. And the white you're marking now with the mouse arrow should be the calcified. No, this should be the herniated disc. Yeah.
Correct. Okay, that is correct. So, so you're removing it microsurgically. How do you ensure that you removed the whole disc and you got the job done? Because
now I would see this open access allows me to use intra-op ultrasound sonographic, and I can see the CSF surrounding the myelin on this level, and I can see whether the herniated disc is gone or not.
Okay, that is correct. So here you do an ultrasound, and you see that's what is this?
This is a myelin.
Okay, and what is this here?
Yeah, you can see now this is the herniated disc. It is not calcified, otherwise there would be a shadowing. So it's not black underneath, so it should be the soft tissue. So it's a herniated disc. Okay,
as you're removing the disc herniation, the neurophysiologist would tell you, okay, there's a delay in the SSEPs now. That is significant change. They tell you there's a significant change and the amplitude of the MAPs has been diminished. What would you do?
I would ask, what is about the MEPs?
It's also diminished, both SSEPs and MEPs.
Yeah.
Delay in SSEPs, obviously latency, and the MEPs amplitude has diminished.
So as usual, when you have your algorithm, I guess, in every OR, what do you do when the SEPs or the electrophysical stats are getting better? You start with your procedure, what you're doing at the moment. You can wait and make another test, look whether it's getting better. But anyway, you have to remove this lesion, and you have to continue. But you should use maybe more decompression indirectly underneath the herniated disc. You should do any kind of doing less pressure on the myelin.
Exactly. So, the algorithm for neural monitoring, right away, you stop the music, you check the leads, you make sure that the leads are connected appropriately. You increase the blood pressure, make sure the patient is not hypotensive, make sure that that anesthesia is on board, make sure there's no metabolic cause that has caused the neural change. And then you reverse your last step if let's say if you're closing osteotomy and the signal change have happened, then you got to reverse that last step. And if these changes persist, what would we do, Dr. Baj?
Yeah, I mean, I think you're absolutely right. You've got to go through that algorithm, and if you have neuromonitoring signals that truly changed, I would say, we've done everything. We've done an awake exam. We've done cases in which we proceed with a decompression. Of course, you've got to first, increase the blood pressure, give steroids, put saline, cold saline in the wound. But at some point, you've got to just go more lateral and get a good decompression.
Mm-hmm. Correct. Sometimes if you're doing an intramedullary tumor and there's a change of signal that you can't reverse, you probably, it's not inappropriate to stop and abort the procedure, at least to make a diagnosis. Okay, so this is the ultrasound, disc herniation spinal cord. And then when you got to get the job done. So you need to check that really remove the disc. You can't look through the dura, you can't retract the cord, so you need to ultrasound to ensure that you got the job done, because sometimes you may have an incomplete resection, and that's not a good thing. Okay, so as you guys noticed, you do a differential diagnosis, treatment, surgical treatment. You got to describe it in 5-6 steps, and then you got to handle a complication. Every single case would flow like this. So this is another case. It's a 55-year-old woman. with a 2-month history with burning paresthesias in the upper and lower extremities, as well as difficulty walking. Her exam was significant of decreased light touch and pinprick in the hands and the distal lower extremities, as well as a positive Romberg sign. She had brisk reflexes in the upper and lower extremities and difficulty with tandem gait. And this is her image. Who wants to take a crack at this? So this is actually a case that I've seen, and I was consulted to see this patient. She was on our neurology service, and they consulted me to see her based on a radiographic read that included a wide differential diagnosis. So what do you guys see? So we'll go through this.
I'm happy to take this,
Yeah,
Nader, because these are some of my favorite cases, because what you said in the beginning is very important. I think they're like, never events in spine surgery, right? And the thing that you never want to do is you never want to biopsy inflammation, transverse myelitis, MS, and you certainly don't want to operate on ALS, right? Those are like the 3-4 things in the cervical spine that we talk about a lot. And one of the things, to be honest with you, I think you mentioned it in your history. The truth is that anytime a female in her 40s or 50s presents with myelopathy, you always have to add that in that differential, the potential demyelinating disease. Similarly, when a male in their 60, 50, 60, 70s, I'm always thinking about ALS. You just have, at some point, you have to put the neurology hat on. And it's more common in degen disease, where you have cord compression plus maybe symptoms that are out of context. But I really like these cases because they really are, you've got to be a doctor before you're a surgeon, right? And these cases force you to be a doctor because that's what's in the best interest of your patient. So the bottom line is, I think the history and exam should make you pause, number one, without even seeing the images. But now when you see the images and you see that non-focal enhancement, it's, what a lot of people refer, I don't know if Dr. Gibbs is here, but she's better at reading this than I am. The so-called patchy enhancement or patchy ill-defined T2 signal, that really should have you pause. And most importantly, especially for the young surgeons in the crowd, my belief is, and let me know what you think, Nader, is in the absence, obviously, of cord compression from a large disc herniation or trauma, the more acute the symptoms, the slower you should go. It's almost counterintuitive. Don't rush these patients into surgery before really trying to get a workup. So, for me, this at this point is non-surgical. It's getting neurology on board. It's getting, working up the differential diagnosis of myelitis, MS, and then reserving a biopsy as a very last option.
Exactly. I mean, this is a case, and actually, because it just goes to show this is a true story. This is a patient that I was consulted to see, and on the neurology service, and you look at this and say, okay, patchy, ill-defined T1 enhancement, and then you have like an extensive cord signal change above and below the lesion. And it's not an expanding lesion, but the differential diagnosis was so wide. So when you want to talk about differential diagnosis in the exam, you'd say, okay, this can be tumor, can be infection, can be inflammation, but less likely it's a tumor because of so and so and so. It doesn't expand the cord. The edema is disproportional to the lesion. Then, as happened to me, the examiner may tell you, okay, since there's an intramedullary tumor is on the differential, they would want to maybe push you to biopsy it. And that's where you need to say, I'd rather finish the workup and get CSF sampling on the patient. And I was asked actually to biopsy this. They biopsy this because after they got the CSF, that's what they ordered, and shows like lymphocytes. So there's some inflammation, but didn't give them a diagnosis, high protein. So we told them to add an ACE level to diagnose neurosarcoidosis, and then okay, you can't treat neurosarcoidosis based on an ACE level, but certainly you can look elsewhere to see if there's an opportunity to biopsy a lymph node, and they got a CT of the chest. You see lymph nodes here, and then you biopsy the lymph nodes, and it's a non-caseating granuloma, and then you treat it with prednisone methotrexate, and I logged the patient in to see what happened to her, and you can see resolution of the cord signal change with significant improvement of the symptoms. So this is a surgical exam, but you'll get one non-surgical case. You must get one surgical case. It's going to be either MS, vitamin B12 deficiency, ALS, neurosarcoidosis, something non-surgical, but you're not going to get 5 non-surgical cases. You're not going to say like you got to get only one. Okay, so this is a 13-year-old male who's complication. Patient presents with positional headaches. What would you think is going on?
The spinal headache.
Yeah, exactly. So how do you want to manage it?
Conservative therapy, maybe bed rest, some Tylenol. You can do Furoset if symptoms are really bad, and then you'd leave blood patch as a last option. Exactly.
See, algorithm. So bed rest, hydration, caffeine, Furoset doesn't work, then a blood patch, and you're done. 30 seconds. You don't want to say bed rest and then wait for the examiner to tell you still has positional headaches. Then you go, okay, we'll give them caffeine and wait, and the examiner will tell you, okay, still has headaches. Go through the algorithm, get to the blood patch so that you can get to the next case. So the 13-year-old male who started complaining of back pain for the past week, the patient thought that the patient pain started following a fall while he was playing football. He's a chubby little, he's 13, but he's 5'8", 5'9". He'd said that the pain started after a significant fall while he was playing football. He's neurologically intact. He got to the doctor the next day, not the same day. No tender disposition in the back, and that's a CT scan. Mid-sagittal, and these are parasagittals, left and right. Who wants to take a crack at this?
I think even our orthopedic colleagues can handle this one.
Yeah, thanks. Who did a CAT scan in a 13-year-old kid? But it's okay. No discussion.
Alex could have gotten the diagnosis from X-ray. He just wanted to see a plain film, and he'll get you the diagnosis.
Yeah.
So what we can see is something that is not quite uncommon. I can see a pars fracture in L4, which means the intra-articular pars is fractured. And I think it explains very well why the patient has acute back pain. It's common in young patients after sports, minor falls. And I think the diagnosis can be confirmed in MRI. We will expect some edema in the pedicle, in the pars. And what we don't want is that this fracture does not heal, and then we have a lysis in the long term. That can lead to a slip to vertebra, L4 over L5, and so conservative treatment can be very good in the beginning with a brace and no sports activities, and not bed rest, but depends on the compliance of the teenager, and bracing should be really a good first step. If it's not possible, if it's still a fracture seen and healing is not happening, then we can use a direct repair procedures. Can be hooks, screws. There's a variety of direct pars repairs. And if the lesion is so badly that it makes symptoms, then finally the fusion L4-5 could be an option. But let's start with conservative treatment.
Excellent. So exactly, that's a pars fracture of L4 bilateral. So you can see it here and the also in the coronal section and the axial section. I mean, Alex went through the whole thing perfectly, but they'll pace you a little bit. If they see that you're really fast and really good, they'll slow you down. That happened to me. They gave me a case, like they showed me a pontine lesion, and I said, image the whole neuroaxis, get CSF, and they started delaying because like I knew it's MS like right away. So they slowed, on purpose. So they want to pace you. So okay, as Dr. Momagani mentioned, patient was placed in a LSO brace for 4 months. Then he comes back to clinic, now on narcotics, skipping classes, significant pain when he's ambulating in the lower back. So what do you want to do? Check with another scan. Has the fracture healed? No, looks worse. So 4 months of bracing did not work, and the patient's taking narcotic. 13, 14-year-old boy is taking narcotics. So as Dr. Momagani said, like, the conservative treatment did not work, so you need to now pursue other options. Now, one thing he pointed out is, he doesn't want to make sure it's not a slip. It's important to get an upright film and ensure that there's no slip already, because if there's a slip, maybe a pars repair won't be a good of an option. So here, there's no spondylolisthesis. And here in this case, I tried to confirm that the pain is coming from the pars fracture. Just, it was most likely come from pars fracture, but to confirm that you can do a pars injection, diagnostic pars injection with the resolution of the pain for a couple of days. So, so one way to repair this is through a pars repair, pedicle screws and L4 sublaminar hooks. Did that many years ago. So, and then you can ensure that the fracture has healed with a CT scan if the patient has some pain. If the patient has no pain, you don't have to. So in this case, let's take a step back. So you do the surgery, and then the patient comes back 6 weeks later with his mom calls you, he has fevers, his incision is draining. What would you do?
So did you use some steroids during your injection too, or was it just local anesthetics?
Local anesthetic.
So this is good. So,
So
when you
post-op, 6 weeks, like 4 weeks post-op, patient has, actually, let's not do that. Let's do 2 weeks post-op, the patient's draining pus from his incision and has a fever. What would you do?
So it is important for me to treat surgical site infections quickly. Don't waste time because it can have a bad influence on your fracture healing. If the infection is ongoing, it can destroy everything. So make some MRI, confirm the infection, and then send him to a wound debridement, or we say debridement is here in Switzerland, debridement and sampling, and put him on antibiotics. I think it's superior to conservative treatment just by giving antibiotics.
Yeah, so what would you do with the hardware? You would keep it or remove it? It's a gram
keep it. It's 2 weeks. It's 2 weeks. Then so it's possible to save the implants. There's no everything is a rigid construct. There's no inlay like in hip prosthetics or any arthroplasties. Everything is titanium, and we can save the implants by early debridement and bioactive film antibiotics.
Yeah, I agree. I mean, most of these infections are gram-positive infections, so you can treat, you can wash out the wound and keep the hardware in. If it's a gram-negative infection, it can be more challenging, requiring multiple washouts or at least swapping the hardware. But it's a gram-positive infection, you can certainly keep the hardware in and treat it successful with IV and then oral antibiotics. So this is a 64-year-old female who noted numbness in her hands of about 2 years. So 2 years numbness in the hands. And then over the past 6 months, she's been complaining of progressive numbness up her arms and then trouble with her gait dystaxia. On exam, she's intact in terms of motor strength, mild sensory loss in the uppers more than the lower extremities distally, and then she had brisk reflexes in the upper lower extremities. And this is her image. Who wants to take a crack at this?
Yeah, I'm happy to jump on this one, Nader. It's we like these, we neurosurgeons like these, of course. So I think you're right. But from the history and exam, you know, it's localized to the cervical spine. I think the fact that she had a negative Hoffman's was interesting, but there's still enough positive findings on the physical exam that localizes to the cervical. But obviously looks like a large, you know, a large, probably intradural lesion that is ventrally located behind C2, causing cord compression and likely causing her symptoms.
Okay, so excellent. So what's the, so it's an intradural lesion. So what's your differential diagnosis?
Yeah, so the, you know, the differential diagnosis for intradural extramedullary lesions, certainly in this area, include some of the more common tumors like meningiomas, schwannoma, certainly neurofibroma. I always include metastatic disease in the differential, as well as maybe some zebras like lymphomas, but the fact that this is relatively well circumscribed and in a common location suggests that this is likely a meningioma.
Excellent. Perfect. So I'll pause here for a second. And as Dr. Bash said, so anytime you see a spinal lesion, you want to put it in a compartment because the compartment will dictate the differential diagnosis. Extradural lesions, they're usually malignant, you know, short of primary bony tumors, but usually like extradural lesion metastasis, multiple myeloma, plasmacytoma. Intradural lesions, extramedullary lesions, they're usually benign. Nerve sheath tumors, neurofibromas, and schwannomas, or a meningioma. Here, this is an arachnoid cleft, so that would kind of maybe tell you that maybe most likely it's a meningioma because you can see arachnoid cleft. Intramedullary lesions, then it's going to be either an astrocytoma, ependymoma, angioblastoma. So put it in a compartment. This will dictate the differential diagnosis. Okay, so this lady is very worried that she was told that she has a tumor. She's asking about options. Should we radiation? Is it biopsy? Is it chemotherapy? How do you want to manage this?
Yeah, I think given the fact that she's symptomatic with myelopathy and she has cord compression, I think this warrants a surgical intervention. I personally don't have a problem with getting if she has a history of cancer, certainly getting a neuroaxis MRI and make sure that she doesn't have other lesions. But to be honest with you, even if this were metastatic, I would probably favor at least an open biopsy with likely resection of the lesion.
Okay, great. She's up for it. She wants to have this removed. What's the approach to this?
Yeah, this is a posterior midline approach, posterior midline laminectomy there from C1 to C3, taking a little bit more from, it looks like it's emanating from the right side. A partial facetectomy on the right. In my hands, I think I would not offer a fusion up front unless I felt intraoperatively I needed to significantly violate the facet. Otherwise, it's a wide laminectomy, more on the right, with a classic, you know, midline, posterior midline approach.
Excellent. So patient was placed in pins, prone, arm stocked, padded, neuromonitoring. Okay, so this is an intraoperative image. This is cranial. That's a laminectomy, C2 and partial C3, maybe a little bit C1, can't remember, but and then cranial caudal. And what do we see here? So this is, so what are these? These are dural tack-ups. And then this is the spinal cord. And what is the stitch? The stitch is in the dentate ligament to rotate the cord gently. This is C2 nerve. Okay, you're in the operating room. You see this, and then you have an enthusiastic medical student, and he said he wants to remove it en bloc.
Yeah, probably, you know, probably not a good idea. You want to try to preserve the rootlets, C2 and C3. So now that you have a nice plane, you've gently rolled the cord over with that tack-up suture, with a suture in the dentate ligament. Totally reasonable to do this piecemeal.
Piecemeal. Okay, so that was done piecemeal. Now, I mean, you can sacrifice the root at that time. I did not, but piecemeal with the CUSA here, and then it's like, if you want to call this preserved root, thank you, but so that's it, and then you close it up, and this is our post-op MRI. So this patient goes home, and then 8 days later, you're operating, you're doing a 2-level TLIF, and then you get a call from your nurse practitioner. So yeah, like C1 was preserved here. A call from the nurse practitioner saying that this patient called, and she's been noticing she's doing great. Her symptoms have improved, but she noticed a little bit of clear fluid coming out of her incision. But she's doing fantastic. No headaches. What would you do?
Yeah, so clear fluid coming from an incision after an intradural tumor work that unfortunately warrants an admission and further evaluation and likely surgical exploration and revision of the incision.
Okay, exactly. So you got to insist that this patient comes in, and you got to be, like always, in general, like for everybody here who's tuning in, be very aggressive with managing complications. There's, you got to go through the algorithm and do it all. Like, don't try to stitch it by the bedside. Sometimes we do that in real life, but like in the exam, you need to be very aggressive about managing complications and go through the algorithm. Otherwise, we're wasting time. So you come in, bring the patient in. You can get an MR through that pseudomeningocele, but it's certainly leaking outside the skin. You got to open it up, explore it, try to stitch it, get the microscope in, try to stitch it primarily. If you can't put a patch, put some Tisseal or fibrin glue, close it in a CSF tight fashion, and put a lumbar drain and drain it for 5 to 7 days, 15 cc's an hour. So do all of these things. Don't put a lumbar drain and then see what happens, then clamp it, then it leaks, then you just go through the algorithm, be very aggressive about managing complications. 60-year-old.
Can I interrupt for a second?
Sure.
Just Dr. Leonardo Soda brought up a good point. So in the chat, he states, doing this endoscopically. I think this brings up a good point that that I think you'll agree with this, which is you want to say things that you do. You want to say things that you know how to do. And if you propose something like, a 4-level lateral inner body, OLIF for degenerative scoliosis, or if you mention something that may not be what we call textbook or, academic textbook, it's okay as long as it's safe, but you better make sure you know how to do it, because the further away from the standard, the more they will 100% ask you, okay, we'll go through the steps. And if you've never done it before, you're going to look really bad. So if you can remove this tumor endoscopically, and I'm not saying, you can or you can't, but if you have done it before and it's safe, you can say it. You can say, yep, in my hands, I'm going to remove this endoscopically, and this is how I'm going to do it. But be careful of saying something that's not standard that you don't know how to do well.
Mm-hmm. Yeah, I agree 100%. And one thing that I don't want to forget to mention, so you look at this and you'd say, okay, some people, and you won't be surprised about, don't be surprised about that, would say, okay, maybe I'll do it anterior approach. And let's say if it's lower, like at C2, at C3-4, like a 2-level corpectomy and opening the dura ventrally. Not good. Maybe it can be done, but now you're transforming an operation that is easy to something, that would warrant a fusion. You're doing a 2-level corpectomy. If it's like, let's say at C3-4, as I mentioned, not here. And you're just changing like you put yourself a different dimension. And another thing that I think about, extradural lesions are more likely to need a fusion. Intradural lesions, less likely that would need supplemental fusion. You can get to the midline easily when you open up the dura. If it's an extradural ventral lesion, they need to do more bony work that would often necessitate stabilization because of the extensive bony resection that may be needed to get to the middle. So like an extradural neurofibroma most likely would need, or an extradural schwannoma most likely would need reconstruction. Intradural lesions less likely. That's kind of a general, not 100% rule, but kind of general thought. So this is a 60-year-old woman with rheumatoid arthritis, 6 months history of progressively worsening neck pain. When she moves her neck, she has a lot of neck pain, neurologically intact. She comes in with this X-ray.
I think Dr. Mamagani said we have a volunteer. Is that true? Who's a volunteer from the audience?
Yeah, I've seen Dr. Alfredo mentioned that he can take one, and I think we have Dr. Du in the chat box as well. But maybe this goes to Alfredo.
I said if it was not a tricky case, but Nader goes to the upper cervical region every time.
Good. Thanks, Alfredo.
Alfredo,
looks like
do
a
not tell that to the
C1-C2
examiners.
instability, yeah.
Do not say, hey, I'm sorry, this is a tricky case. Give me the next one.
Actually, there should be an option. I like this. There should be an option. It's like this case is tough. You can kind of skip a couple of cases. They should have 5 out of 7. It's like the NBA best
best of 7.
Best of 7, yeah.
Yeah, this lady looks like she have an instability in the C1-C2. The anterior to dense distance is increased in flexion films. And given the background of rheumatoid arthritis, is pretty likely that's the cause, right?
Excellent. Exactly, 100%. So atlantoaxial instability, secondary rheumatoid arthritis. So how would you guys approach this? Because that's an interesting case, and it's pretty common to see patients with rheumatoid, with neck pain, and atlantoaxial instability. What do you guys do in those situations? Would you do, Alfredo?
Well, I typically refer this to a rheumatology department, and most of the cases go well with biologics. So the number of cases we tend to fuse with rheumatoid arthritis has decreased dramatically in the last 10 years. So if no neurological symptoms, even with instability in C1-C2 and neck pain, I start with a non-surgical treatment.
Perfect. And that's exactly. So no neurological deficits, patients intact. You always want to take a crack at optimizing. So there's no compression here on this MR. Refer back to the rheumatologist, make sure that the patient's on the appropriate treatments and optimize. You can manage this maybe with a soft color or like just for comfort, or a neck color. And that's what we did. We braced her a little bit as needed and for comfort for 3 months, sent back to the rheumatologist. They optimized the medications, comes back with severe neck pain now, and she's missing work and pretty positional. She moves her neck, has a lot of neck pain, better with the rest. So what would you do at this stage?
Well, I consider moving to the next step, surgical fusion, C1-C2. I have a long talk with patients about the limitations of C1-C2 fusion. But when the Ranagad criteria or Ranagad score for pain is 3 or 4, patients tend to agree to surgery. That I can't live with this pain, move forward. And I have a very good experience with C1-C2 fusion for this very evident instability.
Excellent. So your options for C1, you would want to put. So they'll ask, in the oral boards, they will ask the examiner, like, how do you put a C1 screw? What is your option for a C2 screw? What's the typical length of a C1 screw? What's the typical length and dimensions of a C2 screw? They would ask these questions. So I'm going to ask them. So what do you think, Alfredo, would be like a C1 lateral mass screw length dimensions?
Well, that depends on every patient's anatomy, but it's typically at 28, 26, 28 to 30. And in C2, it depends if you go to the parts or the pedicle, but it typically goes 30 also. I tend to use 4mm screws both for C1 and C2, like Harms, Goel Harms technique. But that depends on the anatomy, high riding vertebral arteries, small pedicles. There's other alternatives to do it.
Okay, and what's your selection for bone graft in this situation? So this is a case that I've done over 10 years ago. 10 years ago exactly. Like, and now these days I put always a cross connector, and my threshold of going to C3 is very low. So this is an early case, but what's your selection for a graft?
I use iliac graft every time for these cases. I start taking the graft out before I do the screws and do the cervical approach, because every time I did the cervical approach first, I'm trying to convince myself that it looks pretty stable. Let's don't do the graft from the iliac bone. I tend to be very positive with that. So I start with the graft no matter what. So I have the iliac graft before the cervical incision.
Excellent. Like, fantastic. In this case, I used to harvest rib all the time. I don't do rib anymore. I just now use BMP if I don't do a decompression. What's your graft selection, Ali?
Yeah, I'm probably a little bit conservative. I used to take iliac crest. I rarely do that now for these cases. I used to do some ribs for pediatrics when I did some of those back in New York. But honestly, now I use locally harvested bone with some DBM plus products. When I do occiput, I use BMP. If I'm doing occipital cervical, I routinely use BMP, honestly, even with a laminectomy. But for C1, C2s, I think some DBM plus products with local autograft has been okay for me.
Would you get into the joint and put a BMP routinely, or in select cases? Sometimes you can get into the joint and hibernate it and put pack some bone in there, or do you sacrifice the nerve root?
Yeah, that's a good question. I think you're going to get different answers from people. We know that there's really no significant harm in sacrificing the C2 root. I typically don't. I like to keep it intact, which makes it harder to get into that joint. So a lot of times I'm relying on posterior fusion, but certainly taking down the root, getting into the joint, doing joint work there probably is going to give you the quickest and more reliable arthrodesis. But I think there's a few ways of doing it.
Excellent. Exactly. So the typical case when you're doing a C1, C2, they will ask you, okay, you put your C1 screw went in okay, and then you're putting your C2 screw, and you put both C1 screws, and you're putting your first C2 screw, and then you see fresh blood squirting out of the tract, hitting the ceiling. What are your thought process? What do you want to do? What's going on?
Is for me, to me, or to Ali?
Alfredo, absolutely, you can.
If I have a suspicion of a vertebral artery injury, I don't go to the contralateral side to do the same. I try to do translam or wires, or go to C3. I try to preserve the posterior fossa vasculature.
Exactly. So yeah, I mean, you would want to do that, and then you would want to get your endovascular guys on board. Like the typical answer usually they'd say, okay, if that happened, and you just need to kind of pack it and abort the case and get the vertebral artery secured. Now, if you have already the contralateral screw placed, you can rod and arthrodese that contralateral side. But if you start with, you don't want to continue. Like if you get an injury on one side, you don't want to put a screw on the other side and risk the other side being injured. So I got that question in the exam, handling a vertebral artery injury. So okay, do I have time for another one really quick? 47-year-old man presented with worsening gait dystaxia of about 2 months, complained of numbness and weakness in all extremities. 4+ out of 5 in the uppers, 5 out of 5 in the lowers, brisk reflexes in the uppers and lowers. And then this is your MRI. Who wants to take a crack at this? And then we're done.
What do you think, Alex? Do we have any volunteers from the participants? Any brave soul?
I don't know.
I can take it. I can take it if no one.
Okay.
Well, I'll start with completing the examination. I do a CAT scan to see if that is soft or calcified. Looks like a narrow spinal stenosis, decompensated with that 2 disc herniations. And my strategy will depend on how calcified the OPLL and that disc herniation.
This is excellent. Absolutely. So guys, this is excellent. So you always want to get a CAT scan. You always want to get a CAT scan. I mean, I get a CAT scan on every single patient. The more you know, the better. That's an axial image, not too much motion on a flexion extension. And this is the CAT scan. So you see there's OPLL, and this is called the crescent sign. Crescent sign means the dura is calcified, not only the OPLL. So, okay, how do you want to approach this?
No anterior, that's for sure. Unless you do a floating technique and do a very, very careful drilling of the posterior part of the disc and leave the calcification in the anterior dura, that's pretty difficult to do. It's challenging. It's not as easy as it sounds. I tend to go posterior laminectomy, fusion, and see how it goes. And I start with that.
Excellent. So that's absolutely the correct answer. However, sometimes the examiner, the next slide is the next slide, would tell you, okay, the patient read about anterior approaches and he's really interested in an anterior approach and insistent.
It can be done. I mean,
okay.
It can be done. I revised a pretty similar case like this. I did the other surgeon did laminectomy and fusion, and the patient pursued with symptoms. I have to go anterior. But I had to, I think in these cases, it's pretty good to have a navigating drill and check with intra-op X-rays. If you're going deep enough, you can be very scary where the drill is. You can see in the middle of the canal, in the spinal canal, and but you have to be very wide with your decompression. I probably do a corpectomy, maybe the 2-level corpectomy there. Start with a easy place where I can find the dura mater, and then go down or up to a difficult place.
Perfect. This is perfect because you don't want to start and get lost. So, you know, they will ask you how to approach an anterior standard anterior approach. You'd say, okay, skin incision transverse, open up the platysma, separate the SCM from the strap muscles, see the omohyoid. I usually divide it, separate the tracheoesophageal complex from the carotid sheath, then get down to the ventral vertebral body, lateralize the open up the prevertebral fascia, lateralize the longus coeli, and then the way you start, you go from normal to gauge your depth. So as Dr. Alfredo said, you get down to the dura here, and then you do your corpectomy. Then you know how deep you are, so you don't get avoid an injury. So this one, we expected to get a CSF that's calcified dura, and we were prepared for it, and actually consented for a lumbar drain. So now these days, I would do a posterior approach in almost all of them, but this one did an anterior approach. So see the dura is all open, and the way we repaired it is I put some small piece of Duragen, put the graft, then sprayed to seal, then put the plate. You don't want to spray to seal and then put the graft in and push the to seal into the. So you gotta put the dura repair on lay. It was a big dural defect. And then you put the graft, then you spray some to seal, then you lumbar drain for 7 days, and it works. Usually it works. It would stick. But these ventral CSF leaks can be very horrible and miserable, actually. This one wasn't. Yeah, I mean, I think the complication here would be, okay, patient comes in with a bump in the neck. How would you do it? You got to go open it up, remove the graft, and try to repair it, put a lumbar drain. I think that's all I have. Another fan favorite is non-displaced facet fracture. You manage it conservatively. Fracture dislocation. always fan favorite too. You know, get an MR or not get an MR before you reduce it. You can say, I get an T2 sagittal MR really quick and show that you care and you're there for the patient, and that's okay. Throughout the disc herniation before putting him in traction. What do I have? This is a patient with a small herniated disc with a foot drop that you shouldn't operate on. Get an EMG, and it's a common peroneal neuropathy. And you get an ultrasound and an MR to rule out like a Baker's cyst. This is a unilateral facet fracture. Put them in traction, then do an ACDF. And that's subdural hematoma. Don't work. You don't want that. Okay. Thank you guys for being there. Thank you, Alfredo, Ali, and Alex for being supreme. Appreciate it. I hope this was a useful session. And who's presenting next week?
This is a great session. What's the slide say? Man found that down inside a bar differential diagnosis.
Yeah. So that's a case that was the case that they examined me on. They told that was my first case. It's like man outside the found down unconscious. What's your differential? And I said seizure, subarachnoid hemorrhage, intoxication,
alcoholism,
hypoglycemia, and then as I'm speaking, you get this.
Yeah.
You know. So.
I think that's a great session, Nader. Thank you very, very much. Next week is Dr. Garoy. He's hosting. Alfredo, do you want to tell us about your guest next week?
Yeah, next week we're going to have Ignacio Barrenechea. He's a neurosurgeon here in Argentina, training in the US. And he will discuss pretty challenging cervical cases, craniocervical. So, Nader. We'll
That's
see you
awesome.
there.
See you there. Looking forward to it.
Great. Thanks, Nader. See
you guys. See you. Have a good night. See you guys.
Bye, guys.
Bye.
Thank you.
Thanks,
Nader.
Alex. See you, Alex. Thanks, buddy.